Welcome. My name is Monica McKenzie, and I'll be your WebEx host for the Novitas Solutions and First Coast Service Options JN Contractor Advisory Committee meeting on the use of urine-based biomarkers in patients with microhematuria. In accordance with the Internet-only manual IOM 100-08, Program Integrity Manual, Chapter 13, Section 13.2.4.3, we are holding today's meeting to promote communications between the MAC and the healthcare community to discuss evidence that may be used in LCD development. At this time, I also want to take a moment to remind everyone that this meeting is being recorded. CMS requires all MACs to record each CAC meeting and maintain it on their respective websites. By remaining logged in and connected via webinar, you will acknowledge that you have been made aware that this CAC meeting is being recorded and you are consenting to that recording. If you do not consent to being recorded, please disconnect from this virtual CAC meeting. Otherwise, your continued connection to this meeting constitutes your consent to this recording. This meeting is open to the public to observe. CAC panelists participating in today's meeting have signed conflict of interest and disclosure to publish forms on file. Please be advised all panelists and CAC members must verbally state their conflict of interest during their initial introduction. In addition, please make sure to identify yourselves prior to speaking to ensure the audio file captures all panelists and CAC members' comments for the transcript. During the meeting, we ask panelists to use the raise hand button located at the bottom of the screen to make comments during each question. Please note the chat will only be available for technical support during the CAC meeting. At this point, I'm going to turn things over to Dr. Megan Landsberg.
All right, can everyone hear me okay? I am going to, we had some technical difficulties here and the slides didn't advance. So I think, okay, there we go. So I will be advancing the slides. All right, so thanks, Monica. And, thanks to everyone both on our panel and everyone attending virtually today. I know it's a little late in the day, so some of you may be missing your dinner to join us, and some of you may still be at work depending on what time zone you're in. So we appreciate everyone taking the time out today. For those of you that may not know me, my name is Dr. Megan Landsberg. I am a board-certified clinical molecular geneticist and director of molecular diagnostics here at Novitas and First Coast. And for lack of a better word, I'm your host this evening. I am joined by our other contractor medical directors, Doctors Anitra Graves, Janet Lawrence, Peter Goldsweig, and Eric Kurtzman, and our panelists today, there we go, that are representing multiple institutions and practices across the country. So we have everybody listed here. And I think we've done a sound check for just about everyone. So if you could all just introduce yourselves in order, as you see on the slide here, where you're joining us from, and as Monica said, state any conflicts of interest that you may have in participating on this panel. Dr. Reagan, if you want to go first, he's here with us.
Yeah, hi, my name is Terrence Regan, urologist here in Florida. I'm representing the Florida Urologic Society, and thank you for allowing me to present. I'll keep my comments brief. There's a number of panelists on here who are much more versed in biomarkers than I am. I'm going to basically put my comments on why biomarkers might be helpful for the clinical urologist. I would just like to state before I get started that the Florida Urologic Society shares the same goals as both Novitas and First Coast, and trying to develop evidence-based medicine or evidence-based cost-effective medicine. So I'm going to essentially focus on a couple of the questions that were sent out, and some I am not going to answer because we have significantly more experienced urologists in some of these. So let me start. As a practicing urologist, we focus on the American Urologic Association guidelines, which has a risk-based strategy for microscopic hematuria. And the guidelines have been changed a number of times over the last 15 years for us to better assess patients and to better appropriately use both upper tract imaging and cystoscopy in those who are most likely to benefit from it. Intermediate risk-based patients, which essentially are those who have 10 to 25 red blood cells, a certain PAC history, smoking, certain age, depending on whether male or female, can opt, according to the guidelines, for biomarkers for in lieu of cystoscopy. And one of the reasons for this is that cystoscopy is for patients from primary care to get the upper and lower tract imaging, if it is recommended, varies from 10 to 50% to as low as 5.9%. And even in the nomogram study that you had in your biography, only 8% of the patients who would have benefited from a cystoscopy had it. So one of the problems that we have is just that, is that patients are not excited to have the evaluation that's recommended, and biomarkers may help us more appropriately screen patients who may be at high risk for, or be at intermediate risk for high-grade cancers. Some of the barriers for patients having cystoscopy are both travel, psychological, costs, and a number of other barriers. But what I'd like to point out, going back to question one, is that who would I consider for biomarking testing as a practicing, what I call blue-collar urologist here in Florida? So these patients who may decide that they don't want to proceed with cystoscopy, and they may have their own reasons for it, but there are a number of anxiety, and they request either anesthesia. But you do have patients who cannot be positioned because of either severe arthritis, ankylosing spondylitis. You have patients who have urethral stricture disease, which require further intervention to proceed with cystoscopy. And although a small minority, but unfortunately not rare, there are a number of patients who've had sexual assault issues in the past are not, and have microscopic hematuria, do not want to have any kind of manipulation. So this biomarker may be certainly indicated for those with intermediate risk disease who are either poor candidates for cystoscopy for a number of different reasons or because of anxiety. In terms of time, I'm going to skip over number 4. Number 3, I didn't quite understand, because if you're asking for a biopsy, I think our goal here is to prevent even more invasive procedures.
Dr. Regan, this is Dr. Landsberg. If I could interrupt just real quick. So the goal here is really to discuss some of the questions collectively, and I'm going to get to each one of them in turn.
Okay.
And so if you could hold off on your comments for just a bit, and then maybe bring them back around when we get to the questions.
I apologize.
Oh, not a problem. I think you've set us up perfectly, but you put our cart a wee bit before the horse. So we'll go through introductions, and then we'll kind of hit all the questions in turn.
Missed that part. I apologize. Okay, sorry.
No worries. Thank you.
Yeah, sorry.
All right, if we could let's just roll through the rest of the introductions, and then we can jump right in to the deep end for our panelists.
I guess I'm next in line. I'm Katia Rezai, as a short version of my full name, Katia Rezai. I'm a pathologist, and I am practicing at Moffitt Cancer Center in Tampa, Florida, and I have expertise in urologic pathology as well as cytopathology. And this is a very nice setup, and I would like to hear, and hopefully I learn and I can contribute as well. Thank you.
Great. Yerlo Tanem, the Chief of Urologic Oncology at UT Southwestern Medical Center. I sit on the AUA Hematuria guidelines. I have multiple disclosures. I'm happy to go through the relevant ones with the urine marker companies. I've consulted with Nucleics, Nonagen, Convergent Genomics, Pacific Edge, Promise Diagnostics, Vesica Health. I think that's all of them. I am conducting research as well. I've R1 grant that I'm a site PI with Nonagen, and I'm also a site PI for a Pacific Edge study credible, and Strata, I was the site PI. Thank you.
Hello, everyone. And I'm John Svakanos. I'm a urologic oncologist at the Icahn School of Medicine in New York. I also consult for Pacific Edge. That's my one disclosure for the urine biomarker. And thank you for the invitation and looking forward to the discussion.
Yeah, hi, good evening, everyone. I'm Jason Hafron. I'm a urologic oncologist in Southeast Michigan. I am the chief medical officer of a large independent urology group, as well as director of the clinical board for a national urology group called Urology Alliance. I appreciate this opportunity, and I have no relevant disclosures for the subject we're going to discuss tonight.
Hi, everyone. Christopher Filson. I'm a urologic oncologist now here at Kaiser Permanente Los Angeles, also affiliated with the Kaiser Permanente School of Medicine here in Pasadena. My only disclosure is that I've got some very indirect support from Pacific Edge for the recent work that we've done in terms of real-world utilization of Cxbladder within the Kaiser system.
It looks like we might still be missing Dr. Schmidt. So, Dr. Shrivastava, do you want to go next?
Yeah, hi, I'm Abhi Shrivastava. I'm one of the urologic oncologists at Atlantic Urology in Myrtle Beach. And I'm also looking forward to the discussion. Thanks for inviting me. I don't have any relevant disclosures.
Fantastic. And last call for Dr. Schmidt. All right. Well, thank you, everybody. Okay, so let's just get right into it. So the purpose of today's meeting, I think we've already learned a bit, is to discuss urine-based biomarkers as part of a workup for patients presenting with microhematuria. So really to examine the associated clinical uses and the improved health outcomes of the Medicare population, and really to determine whether there is insufficient, low, moderate, or high certainty of evidence to support the use of each biomarker type. I just wanted to note, and that's the reason that I put this in a different color, is that although we do acknowledge that many of these services are used in both the pre-cancer and post-cancer setting, we will not be discussing their use in the post-cancer, post-therapy setting as monitoring or surveillance tools. We really want to focus on the initial presentation of patients with microhematuria. So in addition, for our panelists, this is going to be a wee bit out of order, but just as a reminder to please consider the questions from a Medicare Part B perspective. So we're not discussing patient care for those individuals that are sick enough to be admitted to the hospital, nor are we going to be discussing screening of asymptomatic patients as part of these discussions. We do understand that there are a variety of assay types that are used in this type of testing that may either be in clinical production, close to clinical production, currently in development on a research basis. So with your responses to some of the questions, please consider all of the biomarker types when you're responding. As we've already discussed, please remain muted unless you're speaking. And then raise your hand to unmute your phone line to comment. And we really do encourage an open dialogue here and urge you to all share your thoughts with us. We want this to be, a nice open discussion for everyone. Let's see what I have here. So we do have our questions, number of questions that were previously provided to the panelists. For our listeners, they have been posted on both the Novitas and First Coast websites. With the corresponding literature that was included. Now, this list is obviously not all-encompassing of every piece of literature that would be used to inform on any policy that may result from the proceedings of this CAC. So just so that everybody does realize that it's not limited to just those particular publications, but those were relevant ones that came up during the searches. see. And then just a quick background, sort of level set everyone so that you all know where we're coming from. We do understand that microhematuria can encompass many etiologies, right? So urinary tract infection, traumas, medications, a variety of different cancers, bladder, renal, prostate, etc. And that understanding the cause of this microhematuria and what we're looking at is critical for the effective management and treatment of these patients. And urine biomarkers are being developed to aid in that management, both as rule in and rule out services, right? And one of the intended uses that I think Dr. Regan has already mentioned and brought up in the very beginning is to use it as a rule out for the need for cystoscopies, particularly for the intermediate risk population as described in the recent AUA guidelines, right? So given that, I think we can jump straight into the first question, and I will tell everybody you won't see the numbers on here. They're a bit. There's a couple of them that may be out of order, as you saw on the website. They are all there. They're just grouped a little bit differently. So keep an eye out if you're following along. They're not all 1, 2, 3, 4, 5. But our first question for the panel is really to talk about the types of patients that we're looking at here. So how would you select patients that would be appropriate to get urinary biomarker testing in lieu of cystoscopies? And anybody can go first. Raise your hand, unmute yourself, and we'll go.
This is Yara. I'm happy to start. I actually don't even see a raise your hand option for whatever reason.
Yeah, I was actually. Oh, there. It's right down at the bottom. So there. Hopefully, y'all can see it. There's a little, kind of right in the middle. There should be a thing that has hand raised with a little smiley face.
I cannot see it either, even though
Yeah,
I tried
I don't
to.
think we have it on
Yeah.
ours.
Yeah, me neither.
Okay.
Oh, darn. Well, everybody can just jump in then. It's going to be a free for all today.
Perfect. I'll start. People can interrupt me. I think in general, for focusing on patients with microhematuria, I think, essentially all patients would be appropriate for biomarker testing. I think the guidelines, the AUA guidelines at least, focused on the group where there is a risk of cancer ranging from about 1 to 3%, sort of an intermediate risk group, mostly because that's where the current evidence is strongest. However, theoretically, in a lower risk patient or in a higher risk patient, there may be future evidence that will support the utility of markers in that setting. I think we focused on intermediate risk primarily because this is a cohort where the risk is still relatively small, but there's many of the prevalence is very high. There are a lot of patients who have 10 red blood cells, or they've had 3 red blood cells on 2 separate occasions. They maybe have a history of smoking, but not extremely heavy smoking, but they don't have gross hematuria. And there are so many of these patients that are seen by primary care physicians. Most of them are not even referred. And so there's a lot of patients that likely have cancer that's being missed or delayed, and that a urine marker could help either identify those at highest risk or potentially, more importantly, identify those who are at very, very low risk. And many biomarkers have a very high negative predictive value, over 95%, where if you start off with a low prevalence of disease and you have an extremely high negative predictive value, you might be able to avoid cystoscopy, or at least delay an evaluation with a plan of repeated urinalysis down the road. This may also be the case for some high-risk patients. In our guidelines, we didn't have enough way to refine it, but anybody over 60 with 3 red blood cells is a high-risk patient according to the guidelines, but probably has a very, very low risk of bladder cancer. There are ongoing trials that will help evaluate the role of markers in this population. But if you're looking overall, I think it's important to consider markers for any patient. And certainly in a population or in a setting where it takes a long time to get cystoscopy, you would want to prioritize those with positive markers.
Thank you. And I'm just gonna go ahead and advance to the next question because you kind of rolled right into the next question that we had around cystoscopies, which essentially is that of those individuals that are recommended to get a cystoscopy and that should per guideline, what percentage of those individuals ultimately do undergo a cystoscopy? And are there any barriers to them getting that preserved service? And if so, what are they? So given all of y'all on the panel's experience, can you speak to some of those challenges that one has had?
Yeah, this is Jason Heffron from Michigan. Yeah, I think there are significant barriers, and this is why biomarkers are so appealing. Because that what Dr. Reagan said initially is a lot of patients don't prefer a cystoscopy. A cystoscopy is an invasive test. It's embarrassing. It's sensitive. As a urologist, access to urology is becoming more and more limited. There's counties around this country that don't have even a urologist in their county. I practice in a large metropolitan area, and even so, access within our practice is limited. And there has been some publications, going back to 2010, Elias, ELIAS et al., that showed only 13% of patients with high-risk hematuria actually underwent a cystoscopy to various barriers. So I think barriers are a major issue, access, patient preference, and just patients don't want to go and get an invasive procedure, and the literature has shown that already. So that's why a biomarker could be so appealing, is that we could avoid this invasive test that has it's minimal risk, but there's always risk with any invasive procedure.
This is
This is
happy to.
Tanos. I just want to definitely.
Oh. Go ahead, John.
Sorry, here. Go ahead. I was just going to echo that. I mean, I think. Okay.
Oh, sorry.
It's all you.
Yeah. Okay. Sorry. So, yeah, that paper from Elias and all is actually my paper as well. But I think that, the comment of recommended to get cystoscopy is maybe the important part of this question, because the vast majority of patients with microhematuria in the U.S. are not getting referred to urologists or any evaluation whatsoever. Some of it might be hesitation from the primary care physician to send patients to get a procedure. Maybe they're hesitating about imaging. Maybe they're not even aware of the exact guidelines, since they get overwhelmed with so many guidelines every year. But I think the challenge is, at least the consequence, is that many patients are getting delayed in diagnosis. The staging of bladder cancer diagnosis right now has not changed in over 30 years. About a quarter of all patients show up with muscle invasive disease, and half of them will be dead within 5 years from their disease. And so there's an opportunity cost to not evaluating these patients. And the fact is that giving urine is a lot easier, in your primary care physician's office is a lot easier than getting an appointment with a urologist, going to that appointment, getting a cystoscopy. And so these markers are tools that might significantly improve the overall care for patients with microhematuria.
So that's exactly what it's John Sfacchiano. Sorry. It's basically what I was going to say as well. Just to echo what Yer and Jason said, that there is the patient preference, but then there's also the access, and a lot of that is not sort of controlled by the urologist in a sense. And there is one layer above us where a urine biomarker would be able to help us even further risk stratify patients, and be able to help us identify which patients are in the most need, or the ones that don't need it at all. And personally, I think a assay that has a higher negative predictive value, so we can rule out those patients, is probably necessary given the incidence of microscopic hematuria and the volume that ends up getting referred.
I was just going to add, speaking in terms of recommendations, referrals, and performance of cystoscopy, the real world work that we did looking at CX bladder use within Kaiser, where we matched tested patients with untested controls, we saw about a 45% of the untested controls underwent cystoscopy for microhematuria workups. And that's higher than prior kind of population level work, possibly reflecting the integrated nature of the Kaiser system and referral guidelines, et cetera. But if you look at the patients that got tested, incredible uptake of cystoscopy to around 75% in those that were tested and shown to have a higher probability of cancer, and then a complete drop off of quote unquote unnecessary use of cystoscopy among patients that were deemed low probability. So clearly barriers exist and that can be overcome potentially by biomarker results. That was borne out in the work that we did looking at CX bladder. So those types of barriers clearly exist, but can be overcome with biomarkers.
Thank you. And Dr. Pilson, again, you all are preempting my next questions that are coming on these slides. So the next question really was, what are the outcomes, right? So that there are now clearly studies in which some individuals have received biomarkers versus cystoscopy and what the results of those are. Could you all speak just maybe a bit more to, the outcomes for those patients who choose to have a biomarker over cystoscopy? Excuse me.
I can speak. I'm just reading somebody's note about raising hands. We published a randomized trial. It was a multi-center trial that Pacific Edge sponsored called Strata that stratified patients based on baseline risk, and patients who were lower risk in this particular trial, which preceded the current AUA guidelines. So it was a mix of low and intermediate risk patients based on number of red blood cells and age. Basically showed that patients who were randomized to a marker or no marker had almost a 60% reduction in cystoscopy, but no real difference in cancer detection. And even with follow-up, there were no missed cancers in patients who had negative markers. So this actually led to the current ongoing credible study, which will include all patients with microhematuria. But that one trial showed both safety in a longitudinal fashion and a significant reduction in need for cystoscopy, which obviously is preferred by patients if they can avoid it and avoid an invasive procedure and potential risk of the procedure, infection, pain, that type of thing. So at least that was, within the context of a randomized trial, supportive data that a biomarker is both, a reasonable approach for those types of patients.
Thank you. All right, so I wanted to switch gears a little bit. We've talked a lot about the patients and patient selection and whether or not to get cystoscopy, but the next kind of set of questions in the CAC really revolve around these services themselves and the test. I know many of these services have been developed, right, by comparing data from either direct tumor testing to the sampling from the urine, either cell-free, cell pellet. Sometimes the analytes vary between the assays. So to sort of phrase it a different way, we have the question as written is what evidence is there on the differences between performing biomarker testing on specimens that are obtained through direct sampling versus those obtained through urine. I guess to phrase it a wee bit differently, how do we know that what the tests are assessing in the urine actually represents a neoplasm somewhere? And the next question is more specifically, how do we know which neoplasm? So if any of you could speak to the differences, say in gene content, in the type of methodology, et cetera, that's sort of what we're looking for here.
I'm happy to comment. I mean, there are innumerable studies now and also meta-analyses and Cochrane reviews on urine marker performance in the setting of patients with cancer, bladder cancer, and those without. So there are a lot of studies looking at, patients who show up with blood in the urine, you collect the marker, you look in the bladder, you see a tumor, you remove the tumor, and you confirm that the biomarker was positive when cancer was there and negative when cancer was not there. And many of these markers perform with extremely high sensitivities in the 80 to 90% or above for high-grade disease, and probably in the 40 to 50% for low-grade disease. And whether or not they're protein markers or RNA, DNA panels, almost all of them uniformly have a very high sensitivity for high-grade bladder cancer. Cytology, which is a direct visualization of cells, tends to have very similar performance in high grade, but not very good performance in low grade, where the sensitivity may be 15% or less. As far as direct tissue sampling, that's not really, I suppose, relevant to a microhematuria population unless you found a tumor, but there wouldn't be any way to non-invasively obtain tissue. Even the cellular sampling is basically a urine test for urine cytology. In fact, recognizing that urine cytology is used, and there are some genetic assays like Eurovision, which take into consideration genetic changes within cells. Those are all urine tests, and urine cytology is included in the hematuria guidelines as a potential biomarker. As far as comparing prostate and kidney, there are different types of tests, like Tempus Erg, that are urine tests for prostate cancer. There aren't any urine tests that I'm aware of for kidney cancer. And many of these studies look to see in hematuria patients whether or not patients had kidney cancer, and it's very uncommon, but these urine markers do not detect other cancer types. They're not specific, they're not sensitive to those, and they're fairly specific to urothelial carcinoma.
If I may add something, as I think the sole pathologist in the group, I totally agree with you regarding the cell-based biomarkers. When Eurovision first came, it was just finding, sending it for biomarkers and then finding, probably 25 cells. But we kind of came along with, we have to be more directed. So when we are choosing the urine sample for Eurovision, you detect the cells that are abnormal, and then those would be tested for the Eurovision, format. So if you have a cell-based test, they're more likely to be directed at the cells of interest as opposed to just the cell-free, which obviously you don't know what cells are being picked up. But having said that, the cell-based also has its own problems because, for example, between the prostate and urothelial, it becomes hard sometimes even on morphology. Even in tissue, we kind of go a long way to say that if it's a poorly differentiated tumor, whether it's prostate or urothelial cancer. So there are definitely those flaws in whichever way we go. But I think the newer versions of the cell freeze or the biomarkers that are not reliant on the cells, but they're looking at the molecular events in the cells, those are probably going to be much more front and center because they're looking at multiple parameters when they're deciding whether something is abnormal or diagnostic for what we're looking for.
Thank you. And so a question that has arisen. Sorry, go ahead.
Sorry, can I just add one thing to this, because this is probably the most relevant. So we had my group had exactly the same question as question number one. And so we published a paper in Journal Experimental Medicine last year where we took urine, tissue, and blood from patients with bladder cancer. And then we did single cell RNA sequencing. We did O-link analysis. So we looked at DNA, we looked at protein, and we looked at RNA in the urine, in the blood, and in the tissue of patients. Now, of course, these are all patients with bladder cancer, and I think it's the most relevant for question number one. And what we found was there was a 100% concordance on the DNA and RNA level in the urine when you compared it to the actual tissue. So I think the urine is a very good sort of representation of if there is a tumor in the bladder, of what the genomics of that tumor is, and it's also at the level of the protein as well. And just for question number 2, those are the genomics between bladder, prostate, and kidney, whether you're looking at DNA, mutation profiles or RNA expression profiles are completely different. So I think that the urine is a good medium to represent what's happening in the bladder, and really there are signatures that are more specific for urothelial.
I totally agree with your comment. Thank you.
Thank you. And I think you sort of said the magic word there was signatures. So that was sort of, it's not a question on here, but it's a sort of I'll call this an ad hoc question. As you know, there are a number of different signatures, right, that have been identified throughout the different types of bladder cancer. And so could you all maybe opine a bit on, there are multiple different types of assays that are used in urine biomarker testing. And there are, say, for example, 2 different RNA-based services that are, have similar designs, that both have a set of genes on them and are designed to detect non-muscle invasive bladder cancer, yet there's not one overlapping gene between those 2 services. Could you all maybe postulate a little bit how that could occur?
Hi, yeah. I think I'm not going to comment exactly about one panel of RNA versus another panel of RNA. I would point out that the TCGA, which looked at mutations in bladder cancer, found it to be one of the most highly mutated cancers among all cancers. So, I mean, there are a few others like melanoma, I think, but bladder is probably in the top 3 or 4. John can probably correct me. But there were 7 driver mutations on average for every muscle invasive bladder cancer, which, these are high grade tumors. And so, so I think the answer is there is a lot of heterogeneity, and I think that you're going to find that whether or not you look at chromosomal abnormalities or you look at DNA mutations like FGFR and TERT, or if you look at RNA panels, even if you look at the methylation markers, they're looking at different targets. And yet, I think if you look at a panel of mutations, you do cover that you tend to still detect a lot of these cancers because they do have so many mutations each. They're not, a bladder cancer is not one with like one driver mutation and they're all homogeneous, where if you just look for that, you'll find it. And that sometimes makes it easier for different markers to look for different signatures, as you comment on, and even if there's not overlap necessarily.
And yeah, so like you're again hit the nail on the head, where it's that bladder cancer is one of the top 3 most mutated cancers according to the TCGA, and also has a variety of different expression profiles. So I think it's really a matter of statistics, right? How many do you need to have whatever it is that you're looking for? And that's probably, and there's so many that you could probably mix and match the different profiles, different mutations, a combination of RNA and DNA, and probably get to the same, negative predictive value or positive predictive value that you're looking for. And it's a matter of just, picking the ones that, that are probably easiest and have the best probes to make it more reliable and scale. I hope that kind of answers the question.
Yes, absolutely. And so the next slide it's a very sort of in a similar vein, right? So we're going to beat on the tests a little bit here, and it's going to be a bit involved. So to go in a little bit deeper, there are a lot of different types of services, right? There are, as we just discussed, there's protein-based tests, there's DNA-based tests, there's RNA-based tests. Can you all discuss the evidence that exists on the different types of performance of those different biomarkers in the setting? And I just put setting of hematuria, because it's tough to sort of make those cuts, right, between microhematuria versus macrohematuria with all of these different types of services. And so can you all discuss the evidence that has the different criteria for protein tests versus DNA tests versus RNA, either single or multi-analyte?
I mean, there's, you know, I hate to say there are multiple review articles, there's Cochrane reviews, there's many meta-analyses that are published. It's going to be difficult to sort of simplify this. One of the first FDA approved markers was NMP22, which looked at nuclear mitotic, you know, proteins. And, you know, there was, you know, a large trial, I think, in 1,300 patients looking at hematuria and looking at sensitivity and specificity. The overall sensitivity is 55%, but again, I think close to 80% for high-grade disease, a little bit lower for low-grade disease. Since then, there are other, you know, commercially available ones, like Nonagen has a multiplex for like 10 different proteins, and proteins in some ways have stability, so they're easier to test. As far as DNA and RNA, there's multiple commercially available markers, and with studies in thousands and thousands of patients supporting very high negative predictive value, very good sensitivity for high-grade disease. I don't know that, you know, Eurovision is FDA approved. That again looks at 4 chromosomal abnormalities within cells. I think it would be very hard to just summarize the vast literature from the last 20 to 30 years, but if you, for each one of these settings and add methylation into this and add panels that include RNA plus DNA, there's been a very large amount of data that's been published for multiple different markers.
Yeah, and I would go back to, I think, what I mentioned before, right? Any one is alone or in combination, so protein, DNA, RNA, or any combination of the 2 or the 3, I think are suitable for developing and making adequate biomarkers. But I do think we need to have, if it's combination or them alone, ones that will be clinically reliable, that can be reproducible, that can give you, you know, the same sort of confidence every time you use it, because these are somewhat technical. You know, proteins are probably not ideal. RNA can degrade, so you need the right buffers, etc. So I do think any one of these are suitable, and a combination is probably what I would aim for. Something like Triage Plus that uses DNA and RNA, I think makes the most sense, because you can get the backbone of the DNA and not have to necessarily always worry about the RNA quality. And that has high sensitivity and specificity. So I think any one of these, I wouldn't necessarily bias one over the other or combinations of any of the others.
Thank you. Does anybody else on the panel have? Yeah. All right. So I added the next set of questions in here because you know, we had started talking about the types of services and the accuracy. And I know there are a lot of sub questions under this particular question, but it does go back to the you know, as a contractor, and I think as our folks that are listening on the call, right, there are a variety of different types of services, right? So there are single analyte, there are multi-analyte, there have been single analyte services that are FDA approved, that have obviously been out for many years, that have not been recommended by guidelines. Now we have multi-analyte, combination of multi-analyte. There's a lot of different flavors of these services right now. And so given that, how accurate would a test need to be to provide the sufficient confidence in decision-making to forego a cystoscopy? So what we're looking for is, what is the optimal sensitivity and specificity, you know, positive predictive value, negative predictive value that one would want to see in one of these types of services before, you know, it could be utilized as a rule out for cystoscopies. And I think, Dr. Lotan, you said there's meta-analyses, et cetera, out there. So the question, one of the questions under here too, is what is the gold standard comparator that one should be looking at, right? So there's a lot of services that have compared to cytology, and obviously that changes based on whether you're looking at sensitivity or specificity versus Are you looking at a multi-analyte to multi-analyte type of service? So what really is the gold standard comparator that we're looking at here? And anybody can feel free to answer any of those questions under their in or out of order as they see fit.
Yeah, hi Megan, it's Jason. I think I'll just keep going. I'll just pick a couple of those questions. I think, and it was already mentioned earlier, as far as I think the most important, parameter or performance variable to look at is NPV. And I would like to see for a test to be viable or clinically useful with an NPV greater than 95%. I don't think PPV is so accurate, especially when you have a disease, bladder cancer with such low prevalence in microhematuria patients. So I don't think, the PPV is as important, but if you were to say a number, you would probably want to see it greater than 50%. But I think the NPV, greater than 95% is something that I would see that could forego a cystoscopy. As far as your tough question on gold standard comparator, I'll defer that to Dr. Lotan.
Yeah, I think I can comment on how the guidelines, the hematuria guidelines for the AUA viewed it. And when we did an evidence review of essentially the entire literature for urine markers, and the main thought, as you mentioned, is when you're trying to rule out a test, which for better or worse, cystoscopy is the gold standard, even though we recognize that white light cystoscopy, which is what's currently used, can miss some cancers, and that can even be found with markers, but like carcinoma in situ, which notoriously is missed, but that's the best most urologists can do is white light in the office to decide whether or not to take a patient to the OR for biopsy. But because we're trying to decide, can we replace that and will we feel comfortable, the negative predictive value is really the only metric that you can use. And it obviously takes into consideration sensitivity. If you don't have a decent sensitivity, your negative predictive value isn't going to be great. But we thought that a negative predictive value of 95% would meet the threshold. And in our guidelines, we identified 8 markers that had sufficient data from the literature with studies with over 100 patients and at least 25% with microhematuria, and many of them had quite a few more patients than that. And then we gave different levels of evidence based on whether or not these were randomized trials or not. And so, for example, CX bladder triage was a randomized trial, got a strength of evidence of grade A. The other ones were B and C based on whether or not on how their trials were designed. But I agree that PPV really is not the best thing when the prevalence of disease is less than 10%. And at the end of the day, if you have a false positive, all that happens to the patient is they get a cystoscopy, and which theoretically they should have gotten in the first place. So that's not a big deal. And we are concerned about false negatives. As I mentioned, in the Strata trial, there were no false negatives, and none of the patients ended up with cancer after a year. But the guidelines do recommend another UA within 6 to 12 months to confirm that nothing was missed. That's mostly just something that we felt like we needed more longitudinal data for some of these markers. Otherwise, maybe once we get that data, we won't feel like we need to do any other testing.
If I may ask something to maybe clarify it for myself, when we're talking about NPP, PPV, sensitivity, specificity, are we talking about grade based? Because low risk, low grade, and high grade would have totally different sensitivity and specificity, even by cytology, which I am attuned to. So I guess the question that I have, that all these numbers that we have in the AUA and also what you just mentioned, is this all comers? It seems like it would be, because this is the initial diagnosis of microhematuria.
Yes, it's NPV for any cancer, not just for high-grade cancer. Even though if you look at most of the literature, the they do parse out for markers NPV for high grade
Right.
versus NPV overall, but for the guidelines, we looked at NPV overall.
Okay, thank you.
Yeah, when you were writing the guidelines too, within the literature, and maybe we could expand a little bit on the difference between low grade and high grade. It seems that some of the assays that are out there, they do a much better job, obviously, detecting high grade versus low grade. Could you, maybe speak a little bit to the differences in the false positive, false negative detection and low grade versus high grade neoplasms?
I think it's very hard actually to look at the NPV in a hematuria setting because most of the markers have a 99 to 100% NPV, so it doesn't matter if you're looking for NPV for low grade or high grade. The Strata trial, for example, essentially had 100% NPV for high grade. The overall NPV, which because of the way the study was done, it was also done on patients who had cystoscopy, was 99%. So I guess technically you found every high grade and the marker missed, I think, 2 low grades among 350 or so patients. Theoretically, that patient would be very unlikely to have any harm, and if they had another positive UA, would end up getting cystoscopy recommended anyway. But so when it comes to negative predictive value with low prevalence of disease, saying the NPV for high grade is almost certainly going to be higher, but it's not going to be maybe not noticeable. Maybe it's 1% higher because very few patients have cancer in the first place.
Actually, I think that's a really good segue into the last sub question there. And we sort of addressed it already a little bit, is the prevalence of bladder cancer in the various patient populations that were used to validate some of the different biomarker assays. So can you all speak a bit to the prevalence percentages of individuals that have say gross hematuria versus micro versus intermediate risk, high risk, et cetera, and then some of the studies that were performed, what prevalence of bladder cancer in those patient populations were used to validate those assays?
There was a paper of almost 16,000 patients with hematuria that were all had cystoscopy and, if necessary, biopsy. It was based on 7 different cohorts, including the Kaiser cohort and the National Health Services in England, and then about 5 different urine marker studies. And total, there's about 16,000 patients who were evaluated. And so what you find is that in low-risk patients, as the AUA defines it, the risk of bladder cancer is about 0.5%. It's about 1 to 1.5% in intermediate risk, and it's probably about 2 to 4% microhematuria for high risk, but for gross hematuria, it's probably anywhere from 10 to 20%. So vastly different prevalence of cancer.
Thank you. And I think the last question that we have on this slide here is it's a bit of a not necessarily gold standard question, but the question is that so there are analyses of just the clinical factors or nomograms, et cetera. And so what evidence is there in the utilization of biomarkers compared to just algorithms that use a patient's clinical risk factors by themselves?
Happy to answer this. There's actually several studies that have looked at that, and there's an older study looking at NMP22 both looking at a retrospective cohort, but then looking at a multi-center prospective cohort that we published that showed that independent of clinical factors, a positive urine marker increased the likelihood. This was NMP22 tenfold versus a negative urine marker. So a patient with a positive NMP22 is 10 times more likely to have bladder cancer than a patient with a negative NMP22. I think you can see the same in some of the CX bladder studies and I think even, Dr. Filson's paper from Kaiser suggests that, patients who had positive markers were much more likely to end up with disease and evaluation than patients with negative markers. So, and that's looking at clinical, a marker versus clinical factors. But we published a meta-analysis looking at the performance of markers and the likelihood ratios, which take into consideration prevalence, were anywhere from 3 to 10 times more for positive markers, and the negative likelihood ratios decrease the risk by anywhere from 30 to 80%. So there's quite a bit of data, I think, that urine markers can shift relative to the likelihood ratios relative to clinical factors alone.
Yeah, just to add to the details in terms of that, the patients who had been tested and shown to be at a higher risk within the Kaiser cohort had a markedly increased. I mean, the absolute difference is small, but overall, in terms of any tumor detection, it was 1.5% versus 0.5% for the controls of any cancer, and then nearly double. 0.8 to 0.4. This is a relatively low risk group, but it was significantly higher among the patients who were tested, had a higher probability noted by the biomarker compared to standard of care that was driven by just clinical factors. So that's what we observed.
Thank you. All right, so I think we're gonna this sort of wrap up the testing section. So does anybody have anything else they would like to add on the methodologies or the assays, how to use the services? Before we go on to the next slide. Going once. All right. So the next sort of set of questions is more about the utilization and the frequency of these types of services. And so these are sort of just straight up questions that if a biomarker test is performed, and again, this is any biomarker test, right? Protein, DNA, whatever, that meets a certain sensitivity and specificity threshold. If it is negative and cystoscopy is not performed, should a repeat urine analysis be performed? If so, when and at what interval? And then that kind of goes into the next question. The next one is also if that repeat UA does demonstrate microhematuria after a negative biomarker test, should the biomarker test be repeated? And if so, when and at what testing interval?
So that's pretty straightforward question, as long as you're following the AUA guidelines, which were just amended last year. You should repeat a UA in 6 to 12 months. And then if that is still positive or there's persistent hematuria, a full workup is recommended at that time. So, they still need to be retested, and if they're still positive, they should get a full hematuria workup.
I would I so completely agree with the repeating the UA 6 to 12 months, and I would also, just add that there should be an asterisk to this question because it's really about the biomarker. So if a biomarker has a very high negative predictive value, 95% or greater, let's say, then I would say that yes, it should be repeated and, probably can still avoid a cystoscopy in that case, because many of our patients who have microscopic hematuria will have microscopic hematuria for the rest of their life, and we keep on repeating all these workups and they're continuously negative. So I do think if you have a biomarker with a very high negative predictive value, then I would say also repeat the biomarker 6 to 12 months and help that make your judgment call about next steps.
I also agree with the panelist, follow the guidelines. And also if the patients have irritative voiding symptoms, maybe better to kind of take a look at them earlier than at 12 months. So maybe at 6 months follow-up would be good for patients who are symptomatic.
It's sort of a follow-up question to that, right? Having looked at the guidelines, and I know the verbiage, there's flexibility, right, in the timelines of 6 to 12 months. But as one that doesn't work in the field and do these things, to me, there's a big difference between 6 months and 12 months, right? Is there a difference in detection of these services between, say, I have a family member that got this service and they need to be assessed at 6 months versus they can wait until 12 months. And is there evidence and data that supports one of the dates over the other?
I would stratify the patients based on, their AUA risk criteria. If they're low risk, I tend to not follow them up at 6 months, maybe bring them in at 12 months. But if they're smoker, intermediate, or high risk, I would probably bring them in earlier. Also, it's a shared decision making between the patient and, the physician. If the patients are anxious, you can always bring them in earlier and kind of try to reassure them with a negative UA if it comes to that.
Yeah,
Yeah.
I
Go ahead, Yair. Go ahead.
I think the guidelines obviously are, are meant to guide. Clinicians are the ones who are seeing the patients and actually assessing them. When guidelines say 10 to 25 red blood cells, there's clearly a likely, well, as I say clearly, I don't have enough evidence, but there's probably a difference in the cancer risk at 10 and at 25. Same way when they say turn 10 to 30 pack years smoking, 30 pack years may be worse. So if you had somebody on the higher end of your scale, you might be rightfully wanting to do a sooner evaluation. And if they're, on the lower end of the scale, maybe both with age and other parameters, you might say, well, we'll wait a little bit longer. But I'll echo the point, if patients do become symptomatic or they have a change in some fashion, then you should evaluate them sooner. So, and irritative voiding symptoms would be an example where you might be concerned. Maybe you need to evaluate them for other things like BPH or something like that, where cystoscopy might help your decision making anyway. But but I do think the guidelines, like I said, they're providing parameters, but the clinicians will use their best judgment in how to apply those guidelines.
Thank you. And just for those of us, our team that is listening, that there's a certain definition of what an episode of microhematuria is. Could you all provide us some information on sort of how does one define an episode, and how do the patients come back in within a week, a month? And I'm just throwing out numbers here, but what defines an episode of microhematuria, and then when would an individual get like a repeat biomarker testing within that episode?
Most of the referrals we get are from primary care physicians, and generally a referral for microhematuria is based on trace or dipstick testing. So we generally repeat the UA, which is dipstick, and do a micro along with that. And if there is greater or equal to 3 RBC per high power field, we classify them as microhematuria. Otherwise, I don't even proceed with any further workup, and just send the message back to primary care physicians, especially if they're asymptomatic.
It used to be that the guidelines, required two tests to confirm microscopic hematuria, but now really it's just one test, but you still have to rule out potential, non-malignant causes of that hematuria. And if you don't suspect something like that, then it just takes one test to meet the criteria for going down the algorithm of the guidelines. So, in terms of a quote episode, I mean maybe the word is incident of microscopic hematuria, just one episode that more than 3 red blood cells in the absence of clear non-malignant causes is what it is. And Dr. Lotan can add to that because he's on the guidelines panel, but that's my take.
Yeah, I think as you note, UAs are very common. Kaiser data was published by Ron Liu. I think they had 1 million people who had like 3 million urinalyses. So there is a lot of urinalyses being performed in the US right now. And without a perfect explanation for why they're checking what they're looking for in the urine, but there are a lot of patients and they come in for their regular annual checkup and somebody will check a urine on them and they don't have symptoms, and that would be an episode. You're looking at a UA on a given day, and then some of them do have repeated urinalyses, 3 weeks later, or a year later, or 6 months later, and may or may not make it to urologists. The vast majority never make it to urologists, in fact. But if patients are having symptoms that suggest like a urinary tract infection or something else, then that needs to get treated, and then you have to repeat the UA to see if they still have hematuria or not.
This next question we sort of already kind of addressed, right? With the well, you just mentioned delays, and are there any studies that have just demonstrated the percentage of patients that have bladder cancer that may be missed using these biomarkers? So I know Dr. Lotan, you referenced it earlier that there were, in some particular studies there were no, false negatives. Other studies have had a limited number of false negatives, but if there were false negatives, how long, is the delay in diagnoses given the other studies, individuals getting, additional UAs and things like that? How long is the delay in diagnosis if one of these types of services misses a cancer? And are there any, what are the outcomes, adverse outcomes of that delay in diagnosis if the presence of a cancer is missed?
I don't think we have that data. The only randomized trial where patients were followed longitudinally and did not have an evaluation, which is what you would need to know if you're actually even delaying things, is the Strata paper, and there were no missed cancers as far as anybody could find longitudinally. But almost all other urine marker studies essentially are checking the performance of the marker in the setting of, at the same time, doing cystoscopy. So we don't have very good data on what happens when people miss cancer with biomarkers, because those studies don't really exist that I'm aware of.
I do have a question for the panelists. In case you're doing these biomarker testing, then they are positive, but the microhematuria evaluation with cystoscopy and CT urogram is negative. How do you tend to follow these patients? Because I've had a couple of patients like that. And anecdotally, one patient had an upper tract urothelial cancer that was detected like 6 to 12 months later, which I did not pursue investigation just based on a biomarker.
Well, I mean, from my perspective, they still need, if somebody has, for instance, CX bladder and it's positive, they get a scope and it's negative. I would say that would be considered, a negative workup, just as if you did a cystoscopy. And it was like, is that what you're asking in terms of a positive CX bladder and a negative workup?
Correct, yes.
I think if you look specifically at CX bladder, it's not really positive or negative. It's negative or not negative.
Yeah,
and
that's better. Yeah, I agree.
But that's actually how that marker was designed. It was designed to maximize negative predictive value. So it really shouldn't be used specifically for a positive predictive value for looking just specifically at that marker. And so a patient who has a complete evaluation, I mean, a cystoscopy wouldn't have picked up your upper tract tumor either. A CT urogram, if it missed it, that's bad luck. But that you do a complete evaluation. If you don't find anything, then you do the exact same thing you tell every patient who has a completely negative evaluation is, it's a shared decision making. Do you repeat a urinalysis in the future? And we have that conversation all the time with patients who have a negative cystoscopy and a negative, ultrasound or CT, which is to say, just because it's a negative evaluation doesn't mean that, the next episode will be meaningless. And you have to judge with the patient whether or not you want to repeat evaluation in the future or not if it's positive. But the lower risk patients, probably you'd recommend not reevaluating. A patient with 30 pack year smoking history who is 70 or 80, maybe you say anytime you have microhematuria, I want to reevaluate you because you're at higher risk for bladder cancer based on clinical factors.
If I may ask, is this not the equivalent or similar to positive anticipatory result that we get with fish? Because your biomarker is positive, but you're not seeing anything in your workup. But we know that these patients will come back with disease.
I think it's a little tricky. I mean, with Eurovision fish assay, it depends on whether or not you saw something suspicious, whether or not there were atypical cells that went with a positive Eurovision. And most of those studies were done in patients who already had a history of cancer, which is not the focus of discussion today. If we're talking about the prevalence of disease in a patient with hematuria, it's very different than the prevalence of recurrent disease in a patient with bladder cancer, where the recurrence rates is 30 to 70%, and hence anticipatory positives is a concern. In patients with microhematuria, where the risk of cancer is, 2 to 3%, we're not really so much as concerned with anticipatory positives.
Very good. Thank you.
All right, and there's one more question on this slide, and this is sort of a hypothetical, right? Are there any circumstances, right? And granted, of course, this particular conversation is in the performance of biomarkers as a rule out service to not get a cystoscopy. But are there any circumstances that you all can think of where a patient would need both at the same time, right? That, well, I'm going to get a biomarker and a cystoscopy together.
I tend to do that in cases of equivocal cystoscopy findings, in case, patient have recovered from the urinary tract infection and they're having persistent microhematuria, and I do a cystoscopy and the bladder looks inflamed, maybe like CIS-like, and I'm not sure what's going on. Before taking the patient for a biopsy, I might do urine biomarker testing in those circumstances. So in those cases, I would do both.
Yeah, I agree. I do think that there's a lot of other reasons for the microscopic hematuria other than cancer. So I think if you want to rule out cancer, the biomarker is, something that has a negative predictive value. I think CX, has been spoken about. But then, you worry about things like irritative voiding symptoms. You want to check the prostate or cystitises or other things that may require a direct visualization with the cystoscopy. So it's really based on symptoms, I guess.
Yeah,
I would just add to,
Go ahead,
sorry. So I would just add that if it's related to symptoms, if they had gross hematuria, they're definitely going to get a cystoscopy.
Yeah, I would say there's several papers both looking at Eurovision and CX bladder, looking at adjudicating either atypical lesions or atypical cytology. We actually used Eurovision as a reflex test for atypical cytology because the positive predictive value is much higher if there's something else that you find. And also can avoid a biopsy in a patient, as mentioned, with some irregular mucosa where you don't want to biopsy them if you don't have to. These are older patients with smoking and other comorbidities, and a negative urine marker may help with a high negative predictive value, might help allow you to avoid going to the operating room to do a biopsy.
Fantastic. Anybody else have anything to add? All right, so this particular slide was on frequency, et cetera. So the next slide, is the questions I think are pretty self-explanatory. I know, given that the panel is mostly urologists, and we always ask, because it's always a thing within Medicare, right? That what provider types should these types of services be used by? I know that you all are of a certain ilk, and do you use these types of tests in your practices? So I think it's pretty obvious at this point, right, that who uses what, in answering that question. But if you could have a discussion on the types of providers. So say, for example, we've already had a discussion on whether or not this should be in the primary care setting versus a urology clinic, or if there are areas of, for lack of a better word, and I don't know if you all use the terminology of, a cystoscopy desert, if there are individuals there that should be ordering these services versus not. So could you all, discuss the types of providers that should be using these services, and if you use biomarker testings, which ones and why?
As much as we would like the primary care providers to use these tests, I think it's best suited in a urologist office. Also, the primary care physicians are addressing 10, 15 different problems. I don't know if the focus or if a trace blood, even if it is confirmed, even if they are up to date on guidelines from from AUA, would be willing to do this part of their workflow. It is difficult, but yeah, we would. It can be done in primary care provider's office, but I think urologist is the main focus for these kind of testing.
From my perspective, I think it's probably best suited in primary care setting, even though PSA, which is much maligned, is for screening. But when, by analogy, urologists are not the ones who order PSAs on most patients. It's done in the primary care office, and then they refer patients to us who have abnormal PSAs. They're the ones ordering the UAs, and if they see an abnormal UA, rather than ignore it, if they were able to order a urine marker and then refer to us the ones with a positive urine marker, then it would be a much more efficient system overall. And likely, instead of just ignoring the positive UA, which they often do, they would have sort of a rational algorithm for evaluating patients and then really identifying the ones that are most likely do need cystoscopy. So I think that makes a lot of sense, rather than by the time a patient makes it to urologist, then it's fairly late in the process, and already many patients will have been ignored. So having it in the hands of the people who actually order the urinalysis would be probably the best for the overall care of these patients.
I would
I think
agree with
what's
that.
also
Sorry, Jason. I would agree with that as long as it's a micro urinalysis, not a dipstick, as it was mentioned earlier, because otherwise, the dipstick doesn't correlate with the micro urinalysis.
That's a good point. I just wanted to just also bring up, the specialist, the urologist versus the primary care is an important question. But also, I think where the biomarker testing works well with is APPs or mid-level providers. As there's less and less urologists available, we're relying more on APPs, and biomarker testing would be a perfect modality or help with them, as they in our practice we don't allow them to do diagnostic cystoscopy, and this would help them be able to evaluate the patients and then refer them internally to the general or primary urologist as needed.
Yeah, I would also echo that. I think in the setting of a primary care office, family medicine office, even, some OBGYNs who get UAs, if there's clear guidelines and clear understanding of the biomarker, something like CX that has a negative predictive value, I think could be useful, because we can avoid, maybe referrals that are not necessary. And I think we mentioned it early on. It's about access, and this would at least allow some opening to access.
Oh, no. Oh, hold on. We've got Dr. Schmidt is here, but can't. I think, yeah, unfortunately, Dr. Schmidt, I think you ended up coming in as an attendee rather than a panelist. And therefore, I don't think you're able to unmute. I think our folks might be
Looks
able
like
to
they
help.
just fixed it.
Oh, there we go. Fantastic.
Thank you
You.
so
See, we
much.
have a team on
I'm so
top of it.
sorry. I've had a lot of technical difficulties. I kept trying to speak, and it took me until now to realize I wasn't actually speaking in a way anybody could hear me.
Well, you have the floor. We'll give
I
you.
just wanted to add one thing to the practice setting question, which is I spend part of my time in a cancer center and part of my time at a VA. And as a VA, that is a referral VA, so receives patients from 5 different hospitals. This is hospitals in 5 different states. This becomes a real issue of access, because this is something that's incredibly useful when I have a patient who is from 600 miles away, would be driving down for a cystoscopy. And these tests can actually be used by the local clinics, the local primary care clinics, to risk stratify patients who really do need to travel to get a cystoscopy. So primary care, I think, is a really important setting, especially in these low access settings like VAs that refer out of state for urology.
Thank you. And I'm glad you were able to finally get in and finally participate and get you off mute. Just in time. And I guess the last question, and you all don't have to state, because I know we had this discussion very early about whether or not any of you do. You can just say sort of general. I don't think we need to know specifically which ones, but if you do use urine biomarker tests in your practice, if those services are negative, do you forego cystoscopies in your patients? I think everybody sort of answered this particular question already. But if anybody has anything additional to add, at this point, feel free.
I was just going to add one thing that kind of came up at the top in terms of the AUA guidelines. I use Cxbladder Triage mainly because Kaiser, has approved it for use within their system. Beyond the intermediate risk group of patients where guidelines really emphasize, I think there are circumstances where you have higher risk patients that are adamantly refusing to pursue cystoscopy for whatever reason, be it fear, be it access, be it travel distance, whatever, that oftentimes they will be willing to drop off a urine sample. And sometimes that positive result, which will not invariably, but oftentimes come up, will then convince them that they need to go forward with it. So I think there's a circumstance where that can be helpful. And if the result is negative, I generally, like we discussed, forego cystoscopy with the plan to recheck the UA in the future.
Thank you, Dr. Gilson. So you're talking about my father-in-law, is what you're saying. My father-in-law in North Dakota, who would refuse to go to the doctor. That sounds very similar, probably, to a number of individuals on this call. Dr. Schmidt, you're unmuted.
I was just going to echo Dr. Gilson's thoughts as well. I think that there's a role for using this in that intermediate risk category, and to convince patients that they really do need to care, or to stratify how quickly they need to come. So sometimes patients will also say, you know what, I'm not willing, or I can't right now. And so if the test comes back negative, you can always say, you know what, we're okay right now. You recheck the urinalysis and see how that patient is feeling about things at that time. And if it's persistent, then you can say, we've already tried that. We really should take a look now if there's a continuing issue. So it just gives you additional ammunition to work with patients who A, may be hesitant to come in, and B, may have challenges, logistical, financial, et cetera, about getting to care.
Thank you. All right. Well, I think these are the last questions on the list. So I'm just going to open up the floor. We've got plenty of time left. If anybody on the panel has any comments that you'd like to add as we're wrapping things up, the floor is yours, and we can just open it up to questions if anybody has any additional things to add on the panel. No? All right. Well, with that,
Can I just make, I'm sorry, can I just make one real quick this will be just a quick appeal. I mean, I think that we're all used to using markers in prostate cancer for many years. There's quite a plethora of them. If you look overall, they don't perform as well as most of these urine markers. So, but they've been widely available. And, this is a population of patients that, for us who are taking care of bladder cancer and also evaluating hematuria, there's a sense for us that, we're just not doing as good a job as we could do finding these cancers early. And we're all fairly frustrated when we find this disease late and these patients don't do well, because this is a very aggressive cancer, unlike prostate cancer, which tends to be less aggressive. So I'm very hopeful that this does lead to, access to these markers, which I do think will help identify this disease early. Most of our patients accept cystoscopy but prefer not to have it. And if we have ways to increase the efficacy of evaluation and also at the same time reduce cystoscopy, I think there'll be a lot of potential benefit. So that's just my appeal to you.
I'd also like to second Dr. Lotan's appeal a little bit, especially on behalf of women with bladder cancer. Women don't get bladder cancer as often as men do, but when they do, they often present at later stages and will often have a very typical story of, oh, they kept saying it was infection, it was infection, it was infection. And by the time a woman presents with bladder cancer, it's often at more advanced stage. And this is almost exclusively every time a patient who has never had a cystoscopy and who maybe has had microscopic hematuria that was basically blown off as urinary tract infection, even in the setting of multiple negative cultures. So having these tests available, especially in the primary care setting, really would improve earlier detection of bladder cancers, especially in women where frequently their presentations are disregarded and attributed to infection or irritation that it just is not.
I guess I'll give my final plug too, in terms of just highlighting again the work that we did within our system of how well Cxbladder kind of risk aligned the use of cystoscopy to really promote uptake among patients deemed at higher risk for bladder cancer, and then nearly eliminated among those that were deemed as lower probability. And to see that risk alignment of an invasive test that overall promotes uptake where it needs to be used, and then diminishes it where it doesn't, is really remarkable for a test that has grade A evidence behind it and highlighted in the AUA guidelines.
And for me, I would just also just like to echo what was just said. I mean, I think, yes, it's extremely important we identify the patients that have bladder cancer, but I do think that we're completely, and it's been well documented, that we are over performing cystos on patients, whether it is risk stratified or not. Currently a lot of people will do the cystoscopy just because of legal, issues if they miss something, even though the percentages of missing or finding something are so small. So having biomarkers is extremely important. And I think, with Strata and like Chris was saying, with the Kaiser, the Cxbladder triage has a high negative predictive value. It allows us to feel more comfortable where we say, you're okay without a cysto. And I think that's really important for our patients because it is an invasive test. And while most would be like, okay, whatever you need to do, doc, it does come with consequences. It does have, risks of infection and other complications. So I think it's a two-sided picture, and a biomarker helps both sides.
Thank you. All right, well, with that, obviously we've got some closing remarks. Everyone can see the next steps up there on the slide. We use this is information gathering, right? And I appreciate all of our subject matter experts and individuals that participated in this contractor advisory panel today. Using this information, as you can see here on the slide, Novitas and First Coast work in tandem together to determine if an LCD development, LCD is warranted for this particular topic. Keep an eye out, everyone, for those of you will be contacted by Novitas and First Coast, and to all of the folks that have tuned in today, this evening. Thank you all for taking the time out to listen and to participate, and continue to watch our website for additional information. I don't know if Monica, if you have any closing comments, or if I just say thank you very much, everyone, and reach out if we have any other questions.
Great, thanks.
Well, I think that's it. So thank you, everyone, again. Like I said, for taking the time out. I know some of you have busy days, etc., and we really do appreciate it. And having these conversations, it really helps educate all of us. And looking forward to further conversations.
Thank you.
Thank you, everyone.
Thank
Right.
you.
Have a good
Thanks,
night.
everyone.
Thank you.
Have a good evening.
Thank you.